يلا يا دكتور احمد قول لنا دبي بيعملوا ايه في دبي غير ان هم بيعملوا دبي شوكليتس.
اوكي.
بيعملوا حاجه ثانيه؟ طب اتفضل.
As regards the severity, as regards the age of presentation, bilaterality, flexibility, and rigidity. And in all these scenarios, we have to prepare some methodology to understand and manage cases. I think we can try to do this by answering 4 questions. Today I'll present 3 cases treated by subtalar arthroiresis. But I'll start with some introduction. First, the concept of foot tripod. Basically, the foot is designed to touch the surface of walking with 3 areas of contact, as we can see in this picture. How? By the presence of arches. We have 3 major arches, as we can see in these pictures. The arches are maintained like what happened in mechanics. We have a lot of mechanisms to maintain the arches in our feet. The 4 mechanisms are found in our feet. As we can see, the talus is wedged. There is a strong connections between the different parts of the arch, long connection between the 2 ends, in addition to the suspensory effect of tibialis posterior. So the second question, why do we have tripod concept of our feet? To achieve stability and meanwhile allow movements. Because mobility of the foot is very important. We have levels of movement, starts from the ankle. Then the master key of movements is a subtalar joint, which can give 2 positions, so pronation, the position of laxity, and supination, the position of rigidity. This will affect the next level of management, which is the subtalar, which is the mid-tarsal joint. As we can see in this model, we need to play the video. As we can see in this model, the subtalar movement from rigidity and supination into laxity in pronation will affect the orientation of the 2 elements of the mid-tarsal joint. We have 2 elements of mid-tarsal joint. Laterally, we have the calcaneocuboid. Medially, we have the talonavicular. During supination, the talonavicular joint is not aligned with the calcaneocuboid. That's why the mid-tarsal joint is locked. That's why the foot will be arched and rigid. While in pronation, the 2 articular surfaces of the mid-tarsal joint will be aligned, so the mid-tarsal joint will be unlocked and movements will happen and the foot will be supple. This is very important during walking, because initially during the early part of stance phase, we need the foot to be supple and very lax to reduce the shock absorption. But immediately after this, in the middle part of the stance phase, we need the foot to be rigid, because this is called the single stance phase, because the other foot is during the swing phase. And we need this foot to be the strong stand for the body. So we need the subtalar joint to move from laxity, from pronation to supination. And we need to keep this rigidity till the end of the stance phase, because by the end of the stance phase, I'll do the 2 off. And this 2 off should be done on the heads of the metatarsal to increase the lever arm. So patients with severe flat foot will not be able to shift from pronation to supination in the proper time. So he will not be able to do the 2 off on the heads of the metatarsal. 2 off will happen on the mid-tarsal joint, and this will reduce the lever arm, will increase the stresses on the muscles, and that's why the patient will have pain. And accordingly, we can classify patients with flat foot into compensated patients who can do this shift regardless of the shape of their feet, and others who will not be able to do this, and they will have pain with short time of walking or standing. Clinically, during assessment of patients of flat foot, we have to answer some questions. One of them is flexible or rigid deformity by passive dorsiflexion of the first 2 or active heel rise test. We have to check the tightness of the triceps shura. Silver skull test is very important. to decide if we have tightness or not, and if we have tightness, it is just gastrocnemius tightness or post muscles and or Achilles shortening. Integrity of the tibialis posterior should be assessed as well. X-rays in AP will assess the coverage of the talus by the navicular. In lateral view, will check the sag of the first ray. Oblique views and Harris views to assess the presence of tarsal coagulation. CT and MRI could be needed in some cases. Surgeries could be classified in soft tissue surgeries. If we have tricep Shura issue, we can use gastrocnemius recession in isolated gastrocnemius tightness or Achilles lengthening, and advancement of the tibialis posterior Kidner procedure. Bony surgeries, we have the subtalar arthrodesis. The idea is to put some stopper in the outer part of the sinus tarsi to limit the pathological abnormal pronation. So we will shift the range of motion of the subtalar joint into the normal side, and will allow the patient to do the shift from pronation to supination in the proper time during his stance phase. This is one of the cases. We just identify the sinus tarsi, do dilatation till we achieve a good reduction and good correction, then we'll insert the implant. I have 3 cases. The first case, he is a 12 years old boy with bilateral flexible flat foot, as you can see in this video. Has severe deformity, he's complaining of pain, and examination revealed isolated tightness of gastrocnemius. Can we play the other video? ممكن شغل الفيديو تاني؟ أيوه. The patient has flexible flat foot by active heresis. He has a complete correction of the deformity. So I planned for him staged surgery. I do the left side first, a la carte approach. So because the patient has tightness of gastrocnemius, I did for him gastrocnemius recession. I do the patient as well by X-rays has accessory-navicular and it was tender. So I remove the accessory-navicular bone. I do advancement of the tibialis posterior, and I put subtalar screw. This was after surgery. I put the patient in cast for 6 weeks, non-weight bearing cast. Then after that, I removed the cast. We started field therapy, 5 to 10 sessions field therapy, and this was the correction of the left side. After 6 months, we did the other foot. As we can see in this picture, there is the scars of the gastrocnemius recession. I found that after 6 months, the left side started to have some collapse. And I think because the size I choose for him was 9, for the right side, I decided to upgrade and I put size 10, so the correction is better. However, patient was not complaining at all. He was very happy. And this was his video after both feet correction. Again, please can we play ممكن نشغل الفيديو؟ ممكن نشغل الفيديو؟ The next case was a girl, 13 years old, with isolated left flexible flat foot. She was complaining of pain with the activities, evident deformity during standing and walking. On clinical examination, no tightness in gastrocnemius or triceps shura. So I did for her 1 session for the left side. We did excision of the accessory-navicular, advancement of the tibialis posterior, in addition subtalar screw. The patient again was placed in cast for 6 weeks. Then we started field therapy. Again, عايز اشغل. And this was post-operative X-rays. This was the post-operative X-rays. Patient was very happy after a long time of pain and limitation. She started to play sport and she started to even gain some rewards. And this case was done 3 years ago, and a few weeks ago she came to my clinic and she asked to remove the screw. Actually, regarding removal of the subtalar screw, I gave the patient the option. in case the patient will have, of course, complication or any pain, I do trial to control the pain. If not, I'll remove the screw. It happened once with me, and because maybe the patient was crossing the age of 16, and that's why maybe he had the pain. And for this case, she was planning to join some military school, so she decided to remove the screw to avoid refusal in this school. That's why I removed for her, and this is the picture after removal of the screw, 2 weeks after removal of the screw, and the correction of the left foot is almost normal like before removal of the screw. The last case was a 10-year-old girl. The only difference, to cut it short, was the patient had limitation of movement. It was not flexible deformity. When I did the X-ray, I suspected tarsal coalition, and when I did MRI, yes, tarsal coalition was there. So in addition to the surgeries, I added excision of the tarsal coalition. And this was the post-operative X-ray, and this video showing the improvement in her movements from just touch to full weight bearing. And this was correction. Can you play? Yeah. Now this was after physiotherapy. The correction was of the left foot. Of course, other surgeries should be considered, like sliding osteotomy and Evans osteotomy. Usually, I do the sliding osteotomy in adults, whether with transfer and fixation with screws or side blades. And of course, Evans in severe deformities could be mandatory with or without subtalar screw. So the 4 questions to be answered, which is very important: the age of the patient, how much is the tightness of tricepsura, painful or not, and flexibility. Thank you.
Thank you, Dr. Ahmed, for these nice cases. One question.